everybody, the SIM team and a bunch of your residents have gotten together to make an Airway video for you. The purpose of this video is to go through the preparation of intubating and your setup, and then also the actual mechanics of the intubation. Whenever you have a patient, you should always think of three key things. First of all, have you gotten consent about doing the intubation? What is your patient's code status? And then any other alternatives to intubating?
Setting up for Airway is arguably one of the most important aspects of preparation for intubation. There are many pieces of equipment involved, and it is important to ensure that all equipment is functional before attempting to intubate. Equipment includes having suction tubing and a yank hour, a non-rebreather mask, nasal cannula, bag valve mask with PEEP valve, airway adjuncts including an oral pharyngeal adjunct, nasal pharyngeal adjunct, and an LMA, MAC blades, both a 3 and a 4, VL blades, both glide 3 and 4, a variety of ET tubes set up with both a traditional stylet and a rigid stylet, 2 10cc syringes, color wave capnography, as well as end-tidal capnography, and an ET tube holder.
This is Ms. Jones. She's a 64-year-old female, has history of heart failure. Her daughter called because she was short of breath for a couple days. When we got there, she was satting in the low 70s. We put her on a non-rebreather. She's only satting in the low 80s now.
Okay, great, thank you.
Yep.
Katrina, it looks like she's working pretty hard to breathe. Why don't you go ahead and set up for intubation? Okay.
It is imperative that you always place the patient on the monitor, have 2 IVs, and alert the respiratory therapist prior to intubating. Take note that Katrina is quickly assessing the airway at this time. A simple mnemonic that many use is LEMON. L stands for looking for signs of difficult airway. E stands for evaluate, using the 3-3-2 rule. Use 3 fingers to assess mouth opening so that you know the blade can fit, 3 fingers to assess the mandibular space to know there's enough space to displace the tongue, and 2 fingers to assess the distance between the base of the tongue and the glottis. M stands for Mallampati score. Class 1 and 2 are associated with lower intubation failures. O stands for obstruction or obesity. Patients with signs of airway obstruction, such as muffled voice, stridor, and difficulty handling secretions, tend to be more difficult to intubate. Lastly, N stands for neck mobility. Poor neck mobility means you can't position the patient as well. A critical step prior to intubation is to optimally pre-oxygenate your patient. This washes out the nitrogen in the patient's lungs, replacing it with oxygen. It also gets your oxygen saturation as high as possible. Combining these two processes gives you more time to pass your ET tube. The classic teaching is 3 minutes of breathing 100% FiO2 via non-rebreather at 15 liters or 8 full vital capacity BVM breaths. Take note that Katrina is prepping her endotracheal tube for direct laryngoscopy. In addition to inserting the stylet and adding curvature to the distal portion of the tube, you must attach a 10cc syringe and ensure that the balloon fills properly. Katrina is also prepping her endotracheal tube for video laryngoscopy utilizing a rigid stylet. The next step is attaching the bag valve mask to the oxygen wall port and turning up the oxygen past 15 liters. Ideally, one would have 2 wall suction units prepared prior to intubation. It is important to ensure the suction unit is functioning properly and all ports are connected. On top of the suction unit, there is a port labeled patient, which Katrina is connecting the tubing suction to. Katrina is also turning the switch at the back of the wall unit to the on position. Next, turn on the suction device and feel to ensure the suction is being generated at the yank hour.
Katrina, what medications would you like?
I want 20 milligrams of etomidate and 100 milligrams of succinylcholine.
Rapid sequence intubation is the process of giving drugs to induce unconsciousness and motor paralysis to optimize intubation. It is the preferred method for emergency intubation. A general rule of thumb is that for hemodynamically unstable patients, you should use half the normal dose of the sedative and double the dose of the paralytic. At our institution, we tend to favor both etomidate and ketamine for sedation. There are pros and cons to both medications. Etomidate is considered to be a hemodynamically stable medication, and it preserves cerebral perfusion pressure. However, etomidate is also known to have the risk of lowering seizure threshold. There is a theoretical risk of adrenal suppression as well. On the other hand, ketamine is typically favored in asthmatic patients as it preserves the respiratory drive and it is known to have a bronchodilation effect. The use of ketamine is not without risk, as it can cause an emergence reaction and in some cases, laryngospasm. We typically choose between succinylcholine and rocuronium for our choice of paralytics. One of the benefits of using succinylcholine is the brief duration of action. However, there are several risks with using succinylcholine, including hyperkalemia and malignant hyperthermia. On the other hand, rocuronium has less side effects. However, it has a longer duration of action, lasting up to 60 minutes.
Okay, I have 20 of etomidate and 100 of Sux. Katrina, are you ready for your airway?
I am ready.
Okay, great. What's going to be your first attempt and what's your backup?
My first attempt will be DL, my second attempt will be VL.
Okay, great. Okay, pushing 20 of etomidate. Pushing 100 of Sux. Both meds are in.
Okay, let's get the patient into position.
After laying the patient flat and sliding them to the head of the bed, raise the stretcher until the patient's head is aligned with the provider's xiphoid process. Ideally, you want the patient's ear to be aligned with their sternal notch.
Okay, hold down the head for me, please. Scissor. Go in. Okay, I have full visualization. May I have the tube?
Pass through the cords.
Pass through the cords. Tube is in at 23 at the lip with an 8.0 tube.
Okay, I inflated your tube. I
We
see
have color change.
chest rise bilateral.
I hear breath sounds on the right. I hear breath sounds on the left. They're equal. No breath sounds in stomach.
So I took the sticker off on each of the sides of the faces. The prongs are facing the tube over here, the spiky part. I'm gonna go ahead and turn this and clip. Sorry.
Okay, so let's raise the head of the bed to 30 degrees. Let's place an OG tube. Let's get x-ray to confirm placement of the tubes. And respiratory, we could have you come and set up the bed.
Great.
In order to avoid communication error, you should always designate tasks to team members rather than using air commands.
Okay, Katrina, what medications did you ask for post-sedation?
I asked for fentanyl and Versed.
After successfully intubating a patient, post-intubation analgesia and sedation will ensure that the patient does not self-extubate, as well as improving synchrony with the vent. Fentanyl will almost always be the go-to choice for analgesia. Typically, we bolus a patient with 50 to 100 micrograms of fentanyl, followed by starting them on a drip ranging from a rate of 50 to 200 micrograms per hour. Most patients will require sedation on top of analgesia. Propofol is often used in hemodynamically stable patients, whereas Versed is used in patients that are hypotensive.
I have poor visualization of the cords. They seem very anterior.
Does Craig pressure help?
It does not help. I would like to come out, bag the patient, and try with VL.
Okay. Here's your glide.
Thank you.
And I have your ET tube.
Okay.
When utilizing the glide scope, you only want to have a partial view of the cords at the top of the screen. Watch as Katrina holds the rigid stylet at the very top of the tube and rotates it like a joystick. When you see the balloon pass through the cords, pop the stylet and advance the tube further.
Please inflate my balloon. The tube is 24 at the lip. Please attach the BVM. We have tube fog, color change,
I hear
chest rise.
Another helpful adjunct during intubation is the bougie, the gum elastic bougie. This device was initially created to help with blind intubations when someone does not have a view of the vocal cords at all. So there are different ways that you can hold the gum elastic bougie, but regardless of how you hold it, you want to try to get it hyperangulated because it'll help you better pass this during the traditional difficult intubation you'll be utilizing this for. By doing this type of motion, you can basically lift it a bit more anterior. Now, just holding it normally, I like to hold it myself like a pencil because I find that I personally can manipulate it enough if I do it this way. Some other people like to rotate so it's not flapping around in the air, hitting you in the head. And some people even go as far as to preloading the ET tube onto the gum elastic bougie, then rotating it in the situation where you don't have additional help to load it on afterwards. Scissoring, sweeping the tongue. Okay, I have a few of the cords. Okay, I see the bougie going through the cords. I feel it going past the rings.
Okay.
Is no longer passing.
Here's your
Thank-
ET tube,
Thank you.
holding the bougie at the top.
Fantastic. I'm seeing the ET tube going through the cords. The balloon is past the cords. Can you please inflate?
Yep.
I'm 23 at the lip. Fantastic. There are a couple key differences when intubating a pediatric patient. One, most clinicians would say that there's an increased mental stress when intubating a child. Two, their occiput is larger relative to the rest of their body, changing the mechanics of how you're going to utilize a ramp to get the proper air to sternal notch line. And then three, their trachea and vocal cords are more anterior compared to the adult patient, sometimes making an optimal view more difficult. When intubating a pediatric patient, you should have the app PediStat and a Broslow tape readily available to ascertain the proper dosages of medications utilized when intubating these patients. Additionally, you should keep the equation to estimate ET tube size in mind. That equation is H divided by 4 plus 4 for an uncuffed tube versus H divided by 4 plus 3.5 for a cuffed tube. When intubating a pediatric patient, most people utilize a Miller blade. The main difference between a Miller blade and a Mac blade is that the Miller blade has a straight edge to better get the floppy epiglottis of a pediatric patient out of view. When intubating the pediatric patient with a Miller blade, you want to go midline versus going from the side and sweeping the tongue. When going midline, you just want to make sure that you lift the tongue until you see the epiglottis, and once you see the epiglottis, you lift that as well to get a view of the vocal cords. Thank you. I now have a view of the vocal cords. I'm going to pass the tube through the vocal cords similar to an adult intubation. Remove the blade, remove the stylet, and start bagging.
Bag valve mask is a basic foundational airway skill that we need to be experts at. If a patient has a low oxygen saturation, but you are able to bag the patient, you allow yourself time to adequately pre-oxygenate the patient. Moans is another mnemonic that we use to anticipate a difficult BVM. Please refer to this table for all the variables that contribute to difficulty in bagging a patient.
Here's your BVM, and you can turn the knob at the top to give you different values of PEEP that you need. So there are different ways to bag people. One way to get a good seal is something called the CE maneuver. So put your thumb and your index finger in a C shape over the bag, and then put the 3 fingers to jaw thrust upwards. The second technique, you put your thumbs over the bag valve mask, and then you use the remaining fingers to lift the jaw upwards.